I do want to touch on methane a little because one of the drugs we talk about later is related to methane. Bill, you have any comments on methane and its association with constipation when methanogens are in the, because to be honest, one thing we've omitted from the discussion so far of pathophysiology is the microbiome in IBS, because there's a plethora of growing information on this topic, and methane is part of that story, and of course bile acids and other things are part of that story, but I want you to focus on methane for the moment.
Yeah, so one of the most fascinating new topics in the pathophysiology, diagnosis, and treatment of IBS, right? We have been talking about the potential role of breath testing, which is all around the microbiome, where it lives. And what you're referring to, Mark, is what might be living there. And so for bacterial overgrowth, for example, there are patients that have greater hydrogen production or methane production, and your group has done a great job of showing us that methane tends to slow down motility and transit in the GI tract and has been associated with a greater likelihood of IBS-C, IBS with constipation. And it has potential treatment ramifications in that methanergic bacterial overgrowth doesn't seem to respond quite as well to rifaximin alone. So my understanding, your group has been able to show that the combination of rifaximin and neomycin seems to do better for those patients.
But the microbiome is growing in terms of the relationship with IBS. And Ali, you want to comment on bile acids? And then Brennan, I'm going to get you to wrap up. How do we make a diagnosis of inclusion rather than a diagnosis of exclusion?
Yeah, so bile acid malabsorption is another field that is growing in IBS. There are multiple factors that are involved in it. And interesting enough, there is a role for microbiome in it as well, the way a microbiome interacts with bile acid. And that's a field that we're learning, and hopefully it will lead to further therapies that are directed for patients that do have bile acid malabsorption.
So what I'm hearing is there are little buckets that are forming, and there's more data that's needed, but these buckets may help identify subgroups of IBS, and maybe we can really pinpoint a bit more. To your point earlier, if we know this therapy will work better. If we know this therapy will work better. And then ultimately the patient will be satisfied, because it's the lack of response by these patients to pharmacological agents that drives a lot of the doctor shopping and expense. So are we getting close to a diagnosis of inclusion for IBS? You know, you know a lot about stats and epidemiology. If you have 100 people coming through the door, chances are, if you were in Vegas, it's an IBS patient if they have diarrhea, because they're more prevalent versus IBD. So it's a little fallacy to say Rome criteria or just diagnostic criteria are 90%, because just by the prevalence coming through the door, you're going to hit the nail on the head by guessing. So can you comment on getting to that nirvana of a diagnosis of inclusion?
Right. Well, I mean, behind all this is this idea of precision medicine, which is the notion that we can characterize patients more precisely, whether it's through biomarkers, genetic, serologic, whatever, but even psychomarkers, literally just asking people questions and understanding how they're feeling, what they're feeling. These are all types of markers that we can use to maybe more precisely characterize any group of patients. So in IBD, we used to talk about Crohn's and UC. But now, really, IBDologists talk about a whole spectrum, IBD1 and IBD2 and IBD3, a whole sequence of different phenotypes and genotypes. And I think that's where we're headed now, finally, in IBS. So, the diagnosis of inclusion with an antibody, like we talked about earlier, suggests that there's sort of a seropositive type of IBS. I mean, that's really an interesting idea, and one that's biologically sound and can be mapped to a specific treatment paradigm potentially. We need to learn more about that. But I think in general, what we're seeing is a shift from the diagnosis of exclusion, which we published a paper several years ago that even the experts never really believed that, that they just didn't quite feel that was the case. But things have been changing now, and I think we're starting to realize that we can make a diagnosis of inclusion. So we'll hear more about that as you and others continue to accumulate the research.
So do we need a summit on biomarkers or a summit? Because I feel like the IBD folks are much more organized. Perhaps maybe there's more of them so they can conglomerate better to put people into these new buckets that are evolving, the bile acid malabsorption bucket or the maldigestion bucket, for example, sucrose malabsorption. There's so many different buckets that are forming, but we don't gather around them to try and weigh the evidence on all these different.
So one comment, which would be Rome 4, part of Rome 4 was the development of something called the MDCP, which is the Multidisciplinary Clinical Profile. And part of the MDCP, in anticipation of this happening, is focused on biomarkers. At the time we did Rome 4, there really wasn't anything to put in that bucket, but we knew this was coming. And I think there's this misconception that Rome doesn't embrace the notion of biomarkers. Rome totally embraces the notion of biomarkers. In fact, at a board level, I can tell you that we're already talking about that the next phase is symptoms plus. This will not, so the next evolution of the Rome criteria, I can tell you, will not be only symptoms. It will be symptoms and biomarkers, and not just biomarkers to exclude other diseases, but biomarkers to help us to understand what the underlying pathophysiology is, to go more of a precision medicine route. So I think that's coming. I think as part of Rome 5, which, believe it or not, people are starting to talk about, like, starting the process, because remember, it's a 5-year process. Starting in a few years, I think this is going to be a critical element. Certainly will be if I have anything to say about it.